Well, welcome back to Best of the Day from the 55th Annual ASH meeting here in New Orleans. We're still talking about multiple myeloma this morning with Dr. Ken Anderson from Dana-Farber. Now we're going to talk about some of the novel agents that are really exciting. So Ken, thanks again for being with us.
My pleasure.
So several years ago, talking about multiple myeloma, you told me that the myeloma docs were really looking for the rituximab for multiple myeloma. And since then, there have been a number of monoclonal antibodies that have come to the fore. Elotuzumab, I guess, was the first, the anti-CS1 antibody, but then there have been others. And one of the exciting ones has been this anti-CD38 antibody, daratumumab, and there was some data at this year's meeting regarding that. But there's also a new anti-CD38 antibody from Sanofi, I think, SAR 650984. I hope they give it a name soon because I'll never remember all those numbers. So tell us about that antibody and the updates with daratumumab and how well these antibodies are tolerated and what you see as their future in multiple myeloma.
Sure. No, we have been looking for a long time, some of us a real long time, for monoclonal antibodies. So before I mention the CD38 antibody, I'll just quickly say that the elotuzumab, the CS1-directed antibody, really there wasn't a lot of update there, and actually it's good news because the relapsed myeloma clinical trial of elotuzumab monoclonal antibody together with lenalidomide dexamethasone has a response rate that's very high, 80 or 90%. And the progression, and the progression-free survival is really 3 years. And so, honestly, that trial's been going on, so there wasn't
until more people relax, we're not going to hear the data.
Right. So that's a happy problem.
Yeah, absolutely.
Anyway, the second antibodies, there are a couple others I would mention here too, but the CD38 antibodies are coming. As you mentioned, daratumumab has been given breakthrough status by the FDA. There's a second one, SAR, from Sanofi Aventis. There's a third one from MorphoSys, which is now part of Celgene. In any event, especially the first two, daratumumab and SAR, were updated at this meeting. Both agents have single-agent responses, including partial responses, VGPRs, and even complete responses. Both were also described at this meeting to have been combined with lenalidomide and dexamethasone, just like the elotuzumab experience. And not surprisingly, the responses go up. So they are very exciting. I will, just for historical interest here, tell you that I was in on the generation of the first and the association of the first CD38 with myeloma back in 1983.
Oh my goodness.
And it was made, why I share this and it's relevant here, is that the antigen was first described on activated T cells. So it's on activated T lymphocytes, activated cells of all hematologic lineages. It's on endothelial cells. So the concern was, and the reason it hasn't gone forward in the last 30 years, is that there was concern that it might not be possible to give it safely. But what we are seeing, at least so far, is that under conditions and saturation of this antigen on myeloma cells, there apparently is not sufficient binding elsewhere to have a toxicity profile. So anyway, yeah, it is, and it's somewhat surprising. In any event, it's very encouraging because both the elotuzumab, but these CD38 antibodies would be expected, honestly, to work in high-risk myeloma. In other words, it isn't at all expected that if you do immune therapies, the expression or lack thereof of P53 function should matter. It's antibody-dependent cellular cytotoxicity. So we're very excited about the CD38 antibody.
Very good. Well, the other thing that has been really exciting regarding antibodies, both in hematologic malignancies and in solid tumors, has been the linking of a significant toxin to a monoclonal antibody. And there's this agent, BT062, or what they're now calling intuximab ravtansine. So these are seriously toxic agents that are protected, the rest of the body is protected from them because they are tightly linked to the monoclonal antibody, which is then hopefully internalized. The toxin is released and does its work. So how is this agent moving along, and do you think this is going to be something that we may be seeing in phase 2, phase 3 trials in the near future?
I surely hope so. We did do the preclinical, and we are very involved in the clinical trial of this agent. It's the same maytansinoid toxin that's already been approved in breast cancer,
Right.
The TDM1 agent in breast cancer.
Mhm.
And CD38 in myeloma is a wonderful target. It's on all the myelomas. So we actually have the biotest folks from Germany honestly getting married or hitching up with the Immunogen folks in Cambridge, Massachusetts, and we have this immunotoxin. When we did the phase 1 trial of the single agent, there was some MTD established. There were some responses, but it really wasn't as high as we would have expected. So what was reported at this year's ASH, as you said, is lenalidomide dex plus this immunotoxin. This immunotoxin doesn't mediate antibody-dependent cellular cytotoxicity. So the len-dex is not upregulating ADCC here. It's simply the antibody being a carrier to this toxin selectively. But very, I think, promising data here. I mean, we had responses in patients, PR, VGPR, and even one CR now, in patients with multiply relapsed, including refractoriness to the IMiDs and to proteasome inhibitors. So this is exciting, and we're hopeful that it is going to go forward as the first immunotoxin in myeloma.
So is CD138 expressed on other cells besides plasma cells?
No, not really. It's actually much more restricted in that way. So this therapeutic index should be really good.
Very good. All right. Several years ago, perifocine was being looked at in not only in myeloma and hematologic malignancies, but in solid tumors. It was AKT inhibitor. It failed in colorectal cancer and didn't seem to show much activity in multiple myeloma. But there's a new pan-AKT inhibitor, and I'm going to screw up the name of this drug completely, I'm sure, furasertib, and this is being combined with bortezomib dexamethasone. So give us a little bit about the rationale of using an AKT inhibitor in multiple myeloma, especially in conjunction with a proteasome inhibitor, and what are your thoughts about this agent?
Yeah, so AKT is a good target in myeloma because the pathway, PI3 kinase AKT pathway, mediates survival and drug resistance in myeloma. It's further a good target because Teru Hideshima in my group many years ago first described, and many have subsequently shown in all kinds of cancers, different systems, that proteasome inhibitors, any proteasome inhibitor, does inhibit the proteasome and has associated cytotoxicity, but paradoxically or not, activates the AKT pathway. So there's intrinsic activation in myeloma cells, and then there's, in the context of bortezomib, further activation. So the rationale is really quite strong when we and others have used the less selective, less potent AKT inhibitor that was the only one available at the time, perifocine. Even there, we showed that there was synergism with the bortezomib proteasome inhibitor. But the clinical trials there, although they had some positive experiences, were not to the extent warranting further big phase 3 and registration. What's new here is we now have a more potent and broad but selective for AKT inhibitor. And Peter Voorhees from Carolina really was presenting this at this year's ASH, and I thought the data looks very promising. He combined it with bortezomib for now, but it, as I say, it could be combined with any of the proteasome inhibitors. So I think this combination really deserves close follow-up.
Right. Well, if the proteasome inhibitors upregulate the PI3 kinase AKT mTOR pathway, why haven't we seen more information about the pan-PIK3 inhibitors, or the TORC1, TORC2 mTOR inhibitors? I think there's also a PI3 kinase mTOR inhibitor that's in trials. Is that not an effective way to deal with this upregulation?
No, I think it is. There are preclinical experiences looking at various inhibitors, so just TORC1 or TORC2 inhibitors, with or without proteasome inhibitors, PI3 kinase inhibitors, so that's upstream, with or without bortezomib, and now this is the second AKT inhibitor, with or without bortezomib. But the truth is, in terms of clinical trials, there really hasn't been the translation except for the perifosine bortezomib experience, and now this one of this concept, and I think it's quite exciting.
Very good. All right, well, I guess we'll just wait and see about that. Well, the other thing that I remember 5 years ago talking to some of the lymphoma people about kinesin spindle protein inhibitors, and Array has one, ARY520, that now has a name, felanicib, and this agent is being looked at, and it has fairly significant myelotoxicity, but other than that seems to be well tolerated. But now the investigators have discovered that there may be a predictive biomarker for efficacy with this agent in myeloma. So can you tell us a little bit about that?
Yeah, I think the excitement here would be that it's a novel class of agent. Actually, it's a spindle inhibitor, so vincristine is the same. So when you think of novel therapies, we have had prior experience with this class of agents. But in any event, main issue is low blood counts, and there are, as a single agent, response rates in about 20% or so of relapsed refractory myeloma patients. And there is, as reported here, together with bortezomib, a slight increase in that response rate. So going forward, there's going to be a combination study with bortezomib. What you really asked me about is this biomarker called AAG. So this is a protein in the blood. It's actually an acute phase reactant, which apparently binds quite potently to the drug, to the KSP inhibitor. And so it's not the typical way we think of a biomarker, but the lower the AAG level, apparently the more free drug, therefore more activity is expected. So as I understand it, the way they're going to try to select here is for those patients to avoid those patients who have high AAG levels.
Right, so that will at least allow them to select the patients who are most likely to respond. Right. Well, it'll be interesting to see if there are circumstances associated with acute phase reactions that cause problems with this agent.
I agree.
Patients get pneumonia or something in the middle of it. Is that going to be a problem?
I agree.
Yeah. So the final thing I want to ask you about is the new HDAC6 inhibitor. And I know over the years we've talked about the role of histone deacetylase inhibitors in multiple myeloma, especially in combination with other drugs. And this is a new drug from acetylon. I know that Paul has been involved in some of these studies and combining it with Landex, which is now becoming a standard. So tell us a little bit about the role of HDAC inhibitors in myeloma, and especially in association with IMiDs.
Yeah, so in the interest of full disclosure, I've been very involved in studying all of these, and especially the selective one has come from science that came in our group. But in any event, the biology here, Jim, is strong. So the premise of using an HDAC inhibitor to block agrosomal degradation of protein together with a proteasome inhibitor first to block proteasomal degradation was strong in the laboratory. It went to a phase 3 trial with Rickalynstat, HDAC inhibitor plus bortezomib. was a positive trial, but the PFS difference between bortezomib and vorinostat versus bortezomib was only a month because too much diarrhea, low platelets, and fatigue. At this meeting, another broad HDAC inhibitor, type 1/2, called panobinostat, phase 3 trial called the Panorama, was revealed for the first time to be a positive trial. We don't know the exact data, but the PFS is statistically significantly longer. The problem with all of these that are broad acting honestly led us to think about what is the isoform. Can we be more selective for two reasons? Just try to get the biology we want, number one. And number two, if it's more selective, maybe avoid side effects. So here, the AC-1215, which is now called Rickalynstat for the record, was presented by Nupa Raj, and in her presentation she actually talked about both bortezomib and lenalidomide dex. With bortezomib in far advanced patients, they didn't even reach an MTD, so it's
encouraging.
Yeah, it's well tolerated. And there were about 25% responses, 60% stable disease in far advanced patients, bortezomib plus Rickalynstat. What was more exciting, I think, and honestly somewhat unexpected, was combined with the IMiDs, pretty much everybody responds, including people who are refractory to lenalidomide dex. And again, the side effect profile is very favorable. This is an all-oral regimen. So the why we're excited about it is, you know, the HDACs have had a bad reputation over the years because of side effects. But our hope, our most sincere hope, is by being more selective and that the side effect profile can be improved. And you know, we talked earlier about the Lendex platform, upon which proteasome inhibitors have been added, upon which antibodies have been added, and now at this meeting, upon which selective HDAC inhibitors have been added. I can envision someday in the future having an all-oral regimen, or at least of an oral IMiD, steroids, an oral proteasome inhibitor, an oral selective HDAC inhibitor, maybe with or without an antibody, used quite early, and it's going to be very effective.
So I can understand the rationale between combining a proteasome inhibitor and an agrosome inhibitor. What did Newport talk about? What she thinks the mechanism of synergy, if it is synergy, but between this HDAC6 inhibitor and the IMiD is?
Yeah, I can tell you, we do know something about that. So the IMiDs actually do, by themselves, downregulate c-MYC to some extent. Rickalynstat by itself markedly downregulates c-MYC by itself, and the combination is extraordinarily at doing that. And then there's been new targets that have just been identified, the Icaros genes and gene products for the IMiDs. So the IMiDs act through the cereblon complex in kind of a neat mechanism. They are targeted, but they target the degradation of gene products. So it's not like a direct thing. They're targeting a ubiquitin ligase that's responsible for the degradation. In any event, the guilty genes and gene products are the Icaros genes, and I can just share with you that the Rickalynstat AC-1215 has a very important role in that process too.
Interesting. Well, if it downregulates c-MYC, I wonder if it's going to find a place in some of the MYC mutated and upregulated lymphomas.
Well, we'll see. Also presented here for the first time from Owen O'Connor's group in New York City was very positive preclinical data on Rickalynstat as a single agent in lymphoma, and there is a clinical trial which is imminent to begin.
Very good. All right, Ken, we won't keep you any longer.
All right.
Thanks so much. An amazing amount of really exciting information, and it's just great to see all the data and the changes that have come in the last few years in multiple myeloma. It's remarkable.
I couldn't agree more.
Absolutely. So thank you all for watching this segment of Best of the Day on multiple myeloma. I hope you have gotten as much out of this and learned as much as I have. It's truly remarkable. Thanks again.